Now, this water shift into cell can result from either seizures or vigorous exercise or rhabdomyolysis, increase in intracellular breakdown of larger molecule into smaller molecules. Then we have other causes as well, where you just simply a sodium load, so excessive sodium intake. So for instance, patients that are on sodium bicarbonate, for instance, or inadvertently you gave large volumes of sodium bicarb during resuscitative process like cold blue and things like that. Then you have acute salt poisoning. Accidental salt feeding in baby, for instance, can be an example. And then you can have salt water injection or intrauterine installation of hypertonic saline during things like abortion. Then how do you make your diagnosis? Now, again, like I talked to you about during the hyponatremia, and like I said, you want to go look at hyponatremia and look at that again. I also emphasize taking a full history. Full history is really important. And once you get your full history, you assess volume status, you check urine osmolality, and then conditions that would improve this, like DDAVP, either you have partial or complete diabetes insipidus, or adiptic diabetes insipidus as well. So how do you manage it? So now a patient comes to you, sodium is really high. What do you want to do? So you want to give fluid, right? But how do you calculate your fluid deficit? This is where you use this formula. It's called the water deficit estimation. You first get your total body water, and your total body water, you want to make sure that you have your ideal body weight. And your total body water can range between 0.5 and 0.6. So once you get your total body water, you calculate you get the patient's sodium, you divide that by 140, which is the assumed normal value, minus 1, divided by that will give you your free water deficit. And then based on that, you know how to replete the free water. Now the correction rates are very similar to the hyponatremia. Remember, so you want to refer to the hyponatremia slide if you have any questions in that regard. Remember we talked about the free water deficit. So the free water deficit, now you want to give it back. Now fluid selection, it's really important, and that depends on the hemodynamic status of the patient. And then also you want to look at recent or ongoing salt loss. So you want to replace that which is lost. Now, in case you don't have all these things and patient is in renal failure or anuria, not making any urine, that is when you can use either dialysis or to correct the sodium level. So that's what you want to do. Thank you. And if you like this video, just subscribe and hit the notification button. And thank you for watching, and leave any comments below for me. All right, thank you.